upon the chairpersons. First, I would like to call Dr. Anil Kumar Sharma, Consultant Cardiologist and Critical Care, Ashlok Hospital, New Delhi. Please give a round of applause. In the next talk, we will be learning more about how to keep your heart healthy as you age. Our next speaker is a renowned cardiologist and with decades of experience in the field. Currently, he is the Principal Director of Cardiology at BLK Max Super Specialty Hospital, Delhi. Please welcome Dr. Neeraj Bhalla.
Will you project or आप project करेंगे? Okay, good morning everyone, and I must thank Dr. Bansal and Dr. Bansal for the opportunity to speak to you all. You may be wondering that why an intervention cardiologist has chosen a subject like cardiac rehabilitation or rather than an intervention subject. Something like what is in fashion these days is the transcatheter replacement of aortic valves, TAVR, or other advanced intervention procedures. But I thought this is a general audience, and let's shine the light on some very underutilized and very important part of cardiac management. From here. All right. So I work at BLK Max Hospital on Pusa Road, and today I thought we'll talk about cardiac rehabilitation, why it is important, what are the components of cardiac rehabilitation. It's a very underutilized modality, and I'd like to highlight how we can improve or increase its penetration to benefit our patients. So cardiac rehabilitation carries a class 1 recommendation, 1A, which is the strongest recommendation from most of the international societies for all classes of cardiac patients, whether they are post coronary bypass, post angioplasty, stable patients of angina, post MI patients, and heart failure patients. So all classes of cardiac patients should be enrolled or should have some form of cardiac rehabilitation. This is class 1A recommendation. Unfortunately, the adherence to this class 1 recommendation even in advanced societies is 10% or less. In our country it is negligible, and so I thought that it's important that why this area is not being looked at as carefully as we are pouncing to prescribe new drugs, newer modalities of more and more aggressive interventions. So you can see the US, American Heart Association, the Australia, New Zealand Association, the European Society of Cardiology, all subscribe or prescribe cardiac rehabilitation as a class 1A recommendation to be used in all types of cardiac patients. But it is grossly underutilized. Like I said, overall also the adherence or uptake is very poor, and we may say the term negligible applies very well to our country. We are struggling to treat heart disease, what to talk about cardiac rehabilitation, but this is an easy to apply tool and has got lots and lots of benefits, which I will be talking to you in a little while. So cardiac disease, once it gets hold of you, is a lifelong problem. It's not going to go away, and it is marked by high recurrent problems, high morbidity, high mortality, high readmissions to the hospital, especially with heart failure or other acute coronary syndromes. And the reason is that there is poor adherence to guideline directed medical therapy. That's quite common in chronic patients. There is poor compliance and follow-up to the doctors because it's costly, it's inconvenient, patients feel there is no need to. And there is very, very poor adherence to diet and exercise, especially as the index event becomes more and more remote. The patient feels अब तो मैं ठीक हो गया, अब मेरे को दवाई की ज़रूरत नहीं. And we have got angioplasty patients who stop aspirin and clopidogrel within few months. Some stop within a month also. So Poor follow-up leads to poor compliance, leads to poor adherence, and leads to the recurrence in the morbidity and mortality rates, higher cost to the patient, higher cost to society, early loss of life. I hope you are aware that in India, we get heart attacks 10 years before in the West. We lose our lives also 10 years before the West to cardiac disease, and the reason, much of the reason can be attributed to these factors also. So what do we do? Now, what is cardiac rehabilitation? I used to think earlier that cardiac rehabilitation means that after a bypass or angioplasty surgery, you send the patient to physiotherapy department, they start some kind of a exercise program and the patient is called back. But if you look at it, cardiac rehabilitation is a very holistic approach to the patients. So it involves an overall assessment of the patient in their home setting, counseling for various things such as nutrition, exercise prescription within the patient's home, physical activity counseling and monitoring of these patients, management of weight, management of blood pressure, management of diabetic status, management and adherence and compliance to drugs, monitoring of any side effects, and to, in the best possible scenario, to give an early warning symptom before the patient requires to be rehospitalized or land up in an emergency. And these factors can be termed as comprehensive cardiac rehabilitation, not just a exercise prescription. So once you put all these factors into play, you have got excellent results. And in fact, the European Society of Cardiology recommends cardiac rehabilitation as the 5th pillar for management of heart failure patients. 4 pillars are 4 drugs that we might be aware of or might not be, doesn't matter. But as important as these 4 pillars of drug management, which reduce mortality significantly in cardiac patients, they recommend cardiac rehabilitation as the 5th pillar, and this should encompass all these factors that I have said. The problem is that why is there low referral for cardiac rehabilitation? There can be many reasons. Inadequate physician understanding, endorsement, patient appreciation of the benefits, inadequate or cost perception that this is costly, more difficult, how does the patient travel to the hospital or to the place to obtain cardiac rehabilitation. So all these factors lead to a very poor uptake, as we already pointed out. But we can try to overcome these barriers by using or leveraging modern technology, and we can try to give cardiac rehabilitation in a remote fashion which can be monitored, and using nowadays what is available, what technology is available, we are able to offer the same results as in-person cardiac rehabilitation. So you might look at cardiac rehabilitation in these forms. Either it is center-based, where the person comes to the center and does a formal exercise or some kind of rehabilitation. It might be home-based, where the caregiver goes to the patient's house. So you can understand these are all logistically and financially challenging, especially in our country. It might be a hybrid cardiac rehabilitation, where sometimes the patient goes to the center, sometimes the caregiver goes to the patient's place. This may be synchronous or asynchronous. That means synchronous meaning that when the caregiver is there, the patient is doing the exercise in front of the caregiver, or asynchronous, where the patient has done the exercise and reports the results. So there is a mix and match of various ways. But despite all these features, having caregivers physically go or patients physically come to for this purpose seems to be not working. So the idea of this is to try and leverage what are the modern techniques or modern technologies that are available. I think this is not working. So using mobile devices, using web-based programs, using mobile applications, using web-based communication, we can deliver this kind of therapy to patients and result in significant improvement in both adherence to medication, functional capacity, as well as improve their physical abilities. And there is good, robust clinical evidence to support the benefits of remote cardiac rehabilitation. There is evidence from European Society of Cardiology and some important national level societies who have done these studies. The ESC Heart Failure Association said that digital therapeutics based cardiac rehabilitation significantly improved exercise capacity and quality of life with no added risk of mortality. No death or serious adverse events were observed. Similarly, this is a study from German Federal Ministry of Education and Research using continuous monitoring of vitals, educational content given to the patients, medication tracking of the patients. So, and they found that giving this kind of more integrated but remote patient monitoring can result in 26% reduction in days lost due to hospitalization and 30% reduction in all-cause mortality. So these are very dramatic and important figures. Only thing is the process seems to be more cumbersome than simply prescribing a pill and saying that this drug will reduce morbidity and mortality. And we know life is more complex than that. We need more intervention, we need more assessment, we need more monitoring, and that's how we will be able to get results. Similarly, from Australia, remote patient monitoring, 21% reduction in readmission rates, 20% reduction in all-cause mortality. So these are very impressive figures, and it shows that this kind of remote monitoring, remote cardiac rehabilitation really works. So how can we put it in our context? What can we do in India? Is there a way that, or is someone already doing it? So we have got the elements of cardiac rehabilitation. What are they? Which I already said. So you can have a cardiac therapist, cardiac physiotherapist for exercise prescription, a nutritionist for nutritional advice, a patient counselor who can offer some psychological support, a pharmacist who can correctly advise or whether the patient is taking the right drugs, and someone who takes care of this whole thing and is of one point contact with the patient. So if all these elements can be put together, you are now in a position to offer comprehensive cardiac rehabilitation. And thanks to mobile technology, through an application, you can connect the patient to the caregiver doctor at the back end using the intermediaries to provide on-site remote patient monitoring and comprehensive cardiac rehabilitation using all these components. So an exercise prescription can be given by the cardiophysiotherapist. Vital parameter tracking is very important. So then there is adherence to medication, which can be checked telephonically. Diet and exercise prescription, and making the person do exercise in front of you through a video call. And if you add on top of this, if that any emergency support can also be offered during if the patient takes on this program, I think this gives the patient a lot of safety and comfort in utilizing these benefits, and also knowing that in case he or she gets into trouble, there is some emergency service also that can be provided. So these are the ideal components of remote cardiac rehabilitation, and we have now we have been using for the last 1 year or so an effective system that is known as the Life Cardiac Rehabilitation System. And what Life is doing is that they have got an app which the patient has on the phone. The doctor also has a similar app on the phone, and the patient is advised to procure or purchase 6 devices, which includes a blood pressure device, a SpO2 and pulse monitoring device, a weighing scale, a mobile ECG recording device, which is very simple, an activity tracker, and finally, if diabetic, a glucometer. So if the patient has or purchases these 6 devices, then you are on the path of having a comprehensive cardiac rehabilitation program. There is a link that is provided, and these are the people who are specialized, as I already told you: cardiophysiotherapist, nutritionalist, relationship manager, psychologist, pharmacist, and even emergency alerts are available. So these kind of people interact with the patient on a day-to-day basis. They are able to engage with the patient, and as much as the patient engages with them, the patient is seen to derive benefit, and there are some studies to prove that. So this is a clinical study using this particular system. If you see the lower slide, that using the life care system of remote cardiac rehabilitation, there was reduction in all the parameters, systolic, diastolic, there was reduction in the cholesterol levels, there was improvement in the HbA1c level, and there was significant improvement in quality of life. So using this kind of a remote system, also you are able to have both clinical endpoints and measurable endpoints for patients' well-being, and this is going to translate into better outcomes for the patient. So these are a couple of my own patients that we had enrolled in this. So this patient was, I think, a heart failure patient, where for us it is important that the patient's blood pressure should be monitored. The patient should not gain weight unusually. The patient's adherence to medication is important, and the measurement of vitals should be done and conveyed to us. So we found that using this system, patients who take it on have better outcomes. And let me tell you that we are able to avert patients getting into the hospital with heart failure episodes. We are able to better manage patients at home using this kind of a remote rehabilitation system. So with that, I'd like to end saying that this is an underutilized tool. There are various barriers for its adoption, but using and leveraging modern technology, we should be able to give the benefits to the patient in a more structured fashion, and using all the elements of comprehensive cardiac rehabilitation translates into better outcomes for our patients, both in terms of morbidity and mortality. Thank you.
Thank you, Dr. Bhalla, for talking about the, I think, least practiced but most important aspect of cardiac treatment nowadays. And I wish all the hospitals have this cardiac rehabilitation department now.
Yeah.
Particularly with these remote devices and all those things. I know you can treat people's advice in sitting in as far as Assam and...
Yeah, as it is, whatever we are doing, I think all of us are connected to patients through WhatsApp. Many patients are sending us reports, we're trying to advise them, but we are not doing it in a structured fashion. And we are not able to measure the results. We are just doing it individually. But I think whatever clinical studies I have shown from international agencies or international bodies, also the local system, using a comprehensive way and doing it in a manner that can be, we are actually going to get benefit for our patients.
Thank you very much. Because we are running late, we can have questions during the lunch time, please.
Thank you.
Sir, please, if you could present to Dr. Bhalla, please. Thank you. Thank you, sir.